comments. One particular disease that has led to a sharp rise in the number of people being exposed to astronomical medical bills. We're talking about the coronavirus. It's become common these days to see posters circulating online with people pleading for financial support for COVID bills. So we are seeking to put a spotlight on why COVID healthcare is so expensive. So please go to www.citizentv.co.ke/corona #bills and share your experiences there with us and help us keep health stakeholders accountable. This is just part of a series that we're doing. We'll ensure that this is sorted out once and for all. Listen to what you had to say on this conversation.
I think it's really shocking, and there is no essence of course, detaining someone who has undergone medication and is fully recovered, still in hospital.
It's quite unfortunate that even with the existence of NHIF, Kenyans have been left to foot huge hospital bills in the wake of the COVID pandemic. I hope Parliament will pass the NHIF bill. The proposals are quite welcome and will, in a big way, offload the burden from the already depressed and frustrated Kenyans.
I have two quick questions. What is the need for civil servants to have two medical schemes, that is NHIF and a second contracted medical scheme? The second question is that since the government launched the universal healthcare program, so far so good. What is the progress? We need to know what is going on.
And I think the universal healthcare program could have been one of the best programs that could have helped Kenyans in hospital. And I think there has been a lot of politics which has led to the death of UHC. My belief and hope is that the health ministry could not have been devolved. It could have been under the national government for proper management and implementation of the USA program.
The great problem is the provision or people rushing to find private solution to public problems. But that is not sustainable. I think that as a country, we have to really focus on strengthening our public health systems, ensuring that they are working and are able to serve citizens effectively.
If all members contribute to NHIF, why shouldn't there be discrimination when it comes to private individuals who pay NHIF and the state officers? Because we are learned that to understand that most of the state officers are the ones who acquire the services more than how the private individuals are given the same services.
I'll allow you, Dr. Ari, to respond to those issues in just a bit, but let me start with Dr. Chege on this. And so people are watching right now and they're saying their patients are detained, or some of them bodies are detained. Where do they go?
The first place to go is the Kenya Medical and Practitioners and Dentists Council. And I think the CU has really been helpful. And several cases that I've referred, I know people have gotten help. A quicker way, because the board will write a letter.
Yeah.
And now we'll start following up with the facility. A quicker way. If somebody is able to go to court immediately and file it as a matter of urgency, no hospital, no facility should detain anybody, and especially a body. When somebody dies, the body has no value. So whether you keep that body for a month or for a year, it has no value.
Yeah.
And so the family should be allowed to bury their loved one. And then after that, they can be able to agree on a way forward on how, whether, some people can just say, can afford 1,000.
Yeah.
Because yes, we want to maintain those facilities. And we don't want just people to say, I'm not going to pay. But as I said, as we pursue for the ones who are already on that situation now, we are hoping then the UHC, and I'm very sure the CU is going to explain much more about the UHC. Once we implement fully the UHC, then we'll not have those scenarios, because the ones who can't really afford will be able now, the government will be able to come in and pay for it.
Okay.
Yeah.
Dr. Kamunyo, here Dr. Wandia Njoya is saying that we are making a big mistake equating NHIF to healthcare. NHIF is just money. It is not doctors, nurses, medicines, or even hospital beds. And if all adults must pay for healthcare, why is it an insurance fund? It should be a universal healthcare budget line from the exchequer. Do you agree with Dr. Wandia?
Great comment. First of all, universal health coverage is not a scheme. Universal health coverage is not an event. Universal health coverage is a state where the citizens have access to quality health care without suffering financial hardship. To get universal health coverage, there are different models. If you recall in 2018 when we piloted a certain model, which was the input-based model, whereby the government financed, the human resources, commodities, etc., and then all the citizens in the pilot counties would go there and access services. Now, the challenge or the learnings from that is that it's not a sustainable model. Now, this time, because UHC, we have been on that journey continuously to ensure that everybody has access, we are going to a model called output financing model or an insurance model. And why is this model more sustainable? Because it is insurance-based. So every citizen is what we are striving for, and what the bill is also striving for, becomes a member of NHIF, which is the fund, right? Now, when their premiums are paid, when they do need to go to hospital, they can access any of the hospitals and our packages and get their treatment without paying out of pocket. Now, that is the state that we seek to get to. So everyone pays, and everyone who can pay to pay, and then those who cannot pay are the ones that we identify and support.
Okay. Frank here on Twitter says, early this month I was to undergo a CT scan. I went to hospital and was told that they have sent for approval request to NHIF. After 1 week, NHIF rejected the request. I visited NHIF Upper Hill offices and I was told that NHIF only approves CT scan for cancer patients and accidents. Is this true?
No, that is not true at all. And what we've been working towards is to improve, number one, the turnaround time for the approvals. And this is through our digitization process. And for CT scans, for example, or imaging, once the request is made by the hospital, we have a team of case managers who work 24 hours to be able to respond and approve those requests. And should anyone get a challenge of that nature, we have our helpline that they can call to complain or to get an explanation. So like in such a scenario that it was rejected, there must have been a reason for the rejection. But most of them that are valid requests from the hospitals for valid ailments, for valid investigations, that is usually reimbursed. And we've improved the turnaround time now.
One Mr. Mugera says, why is it that NHIF systems hang during the weekend? And when it happens, there are rarely anyone to sort out the mess, thus forcing the patients to pay cash, which is usually an uphill task to get a refund. What is so hard with NHIF agreeing with service providers that in the event of a system failure, the patients get treated and the account to be updated when the systems resume?
Yeah, a great question. And one thing I would reiterate again, if anyone gets challenges accessing services, our call center is actually 24/7.
What's the number to that call center?
Yes, I will give it to you. Okay. And then, and there's a team that is there to assist you at all times. That is number one. System downtimes is dependent on many things. On the networks, and sometimes at the local place. Or the networks across, or even at the office. But what we've done is ensure that even working offline is possible, and then getting uploads. And this is part of the digital transformation that we are doing right now. And especially now that we are going towards e-claim, for example, whereby the hospitals will be able to submit those claims and requests in real time. And get feedback. So this is part of the digitization and part of the transformation process that we're going through.
Honorable Chege, isn't there anything you can do about the doctors who somehow moonlight? And you're the one who brought it up. In the public sector, you charge 5,000. When you go to your own private practice for the same service, you're charging 15,000, and you're even most likely to refer a patient from the public to your own private facility. Isn't there anything you can do as legislators to tame that?
Well, this is quite a discussion, and I don't think if we start it today, it will end. Because basically you find that a lot of people have seen facilities where maybe the private sector, you're told you're employed here and you cannot work elsewhere. But within the government, you find that when people become permanent and pensionable, somehow they operate the way they want. And sometimes you find that because people are human, you find that somebody might not even be at work, within the hours that they're supposed to be there. That's supposed to be a management issue, not even a legislation issue. And secondly, then some people even make machines not to work so that they can send patients to their own private clinic. And I think that's where the humanity, if you're human, those are things that are wrong. And I think you're in the wrong profession if you are in a facility where you're making even the machines not to work, or you make it so difficult. You find that there's nothing happening, but you make it so difficult to offer services in a public sector or a public facility so that you can tell people, now we can refer you. A patient needs chemo, and then you're like, no, we have a line up to 30th, but there's a facility. It is illegal. You know, and I think some of these things, apart from now the management and the people who are in charge of such management, we should be able to call out these people. Yeah. Because at the end of the day, you know, you're taking advantage of somebody who is already sick, somebody who needs your help. And some of these things don't even need, you know, laws. We can make laws and 1,000 laws, but it needs a human heart. Somebody to see somebody is suffering, somebody needs chemo, somebody needs to be admitted, somebody needs, you know, an ultrasound. Yeah. But, you know, and I think part of the challenges we have had with NHIF is the fraud, where facilities would even claim more than they had, and that's why we went to the issue of digitalization. Because you find that might be a facility that can only admit 20. At the end of the day, they are claiming they had 100 or 200 patients admitted. And I think NHIF has really worked closely with the Ministry of Health. Yeah. And the things are now working on, and I think with biometrics now, so nobody should now be able to go and use somebody else's card because it was happening. Okay. Others had just employed someone to just sit in a back office and fill in the NHIF forms and claim that we have treated so and so. And especially now such a case where we have said somebody goes in and you're told this facility is not covered. Sometimes we'll discover that you're told it's not covered. You paid cash, but NHIF was billed. And those are some of the gaps that were there, and that's why I said with the reforms that we are now going through with the NHIF, we are hoping now we'll be able to streamline and make sure that we, you know, we get proper health care. But we also have hospitals charging people up front. If you want your patient to be admitted, hospitals now tell you to pay 300,000 up front or 400 or even 100. If you don't have it, they will not. It is actually illegal because if it's an emergency, any hospital, whether you're private or public, you should first admit and administer, you know, whether it's first aid, if it's an emergency, you first take, because it's a matter of life and death. You should be able to first serve the patient and then ask for money. And that's why I say we do it. See, maybe the fears of the facilities, like maybe this person is not going to pay us. But what is much of more value? You can be able to go look for money, but once you lose a life, you cannot reverse it. And that's why I said some of these things that are happening within our health sector, it just needs to take a human heart. It needs all of us to assist, all of us to come with proper policy. But at the end of the day, there's somebody who really does the job. There's somebody who really interacts with this patient. Yeah. There's somebody who is sitting billing, you know, for, you know, crazy bills. Yeah. Just put yourself in the shoes of that person. And the people who have been given responsibility, whether you have been given a responsibility to be in NHIF, just know that if you aid people to defraud NHIF, then many Kenyans will not get the services. Then you're also to blame. And I think we need to start taking personal responsibilities. You ask whether UHC will cover everything. It might not cover everything, because if I want, might be cosmetic or might be some things I don't know whether they'll be covering dental and optical. Some of the optional things that is not a must. I think the priority will be given to really, you know, those essentials that is a must and where you need really a lot of help. But at the end of the day, we hope that NHIF and the facilities, they're going to be very transparent. Yeah. Now with the digitalization, I want the CEO to give that hotline, that helpline. Yeah. Yeah. So that if any Kenyan is told you cannot be, this one is not covered, and we have actually agreed with the CEO that when somebody walks in the hospital, they need to have proper, you know, like those papers that you find written, legible. Yeah. Are you an NHIF member? This is the steps to do, because some facilities also what they do. When you get in, they don't ask you whether you have an NHIF card. Yeah. Then you get admitted. When you are being discharged, then you say, I have an NHIF card. Then you're told, no, you never disclosed in the beginning you had, and then NHIF will not cover. Those are some of the cases I've dealt with personally as a chair. So it is also a responsibility of NHIF to inform their members. Yeah. Clearly that this is the steps when you go to the hospital. The first thing to produce is your NHIF card, so that it is recorded. Number two, these are the services that are covered, and these are the services that are not covered. Okay. So that we don't have some of the hospitals telling patients, pay for this is not covered. But at the end of the day, they are billing
NHIF?
NHIF.
Okay.
Yeah.
Dr. do you have the hotline number now?
Yes, it's 0800 720 601.
0800 720 601.
601.
And this works even right now. If I call it, someone will pick.
Someone will pick.
Are you sure about that? We'll call it in just a bit. Thomas Ndirangu says, please ask NHIF CEO what is the rationale for having different NHIF limits in different hospitals?
That's a great question, and that's something that we're dealing with. In fact, starting from what Mheshimiwa said, the secret to this financial protection is risk transfer, and which is getting to NHIF. And for us to be able to sustain that is to have rates of reimbursement that are standardized. And that is the direction we are going with the reforms. Historically, there were different reimbursements because of different contracts that existed with different hospitals. But right now, in the new contracting cycle that we're going in for 2021 to 2024, we're going to have two sets of contracts. That is comprehensive care contracts, where all the charges, all the reimbursements are standardized, and then non-comprehensive ones, whereby we have certain standardized benefits, but if members choose to go there, then they might be exposed to payment of a little bit extra. But what we are driving towards is to ensure that majority of our contracts and our providers are comprehensive, so that every Kenyan who goes there does not spend out of pocket. And that is something that we're gearing for. Like now, all the public facilities, we've onboarded them, and ensuring that the counties, that the services also are adequately provided. Because universal health coverage starts from primary care, also preventive and promotive, all the way to curative services. And NHIF, where it comes in, is reimbursement at the point of hospital. So we need to transfer that risk by everyone being onboarded to NHIF.
Okay. Daniel Ntakia Somba says, ask NHIF CEO why it takes so many years for NHIF to accredit new health facilities. Very brief.
This has been a process going on. And to get it right, we had to really go back to the drawing board to ensure that now we have contracts that work for all providers. We're talking about close to 8,000 providers, majority of whom are public hospitals, another 24% are private hospitals, and another 6% faith-based. So it has been a journey, and right now we are confident that we are on the home stretch to ensure that we achieve one of the big four agendas of His Excellency the President, that every Kenyan has access.
Mwesh, should we have devolved healthcare in hindsight?
Well, in some counties it has worked very well. And now they're able to give services that they had to refer people either to Nairobi or to provincial facilities. In some counties, it has not worked. And this depends on maybe the governor and the health system and how they have managed. I want to give an example of a county like Mombasa, because I've been there. And I want to say the governor has really done a lot for the Coast General Hospital. I want to single out also like MTRH. It's a national facility, but has really worked for the entire of the western region, the Rift Valley. And so some counties, the services they are getting when health was devolved are fantastic. They are able to access to a lot of services. But the problem we have is about the human resource. Where we find that one, like today, you find like sometimes they delay payment of the health workers, which has been demoralizing, and especially at this time of pandemic. Because the health workers, they have to wait for the counties to be paid by the exchequer or by treasury, then they pay them. And sometimes you find that if money delays from treasury, then they are not able to be paid. And so it has really not been fair for the health workers. And part of, if I revisit the BBI, part of what was proposed was to have a health service commission. For example, when we have teachers are all paid at the same time. They're all paid by the national government. One of the biggest disadvantages of devolving health, and especially human resource of health, is when the doctors want to come in and to go in further, maybe to master their studies, then the counties continue paying them, but they're not offering services to the counties. They come back to school. And the national government, they're not able to send an alternative or a different doctor to go there. Some of these counties, I was in Lamu, and they were telling my committee, they have advertised so many times, but doctors don't want to go there. They don't want to go to Lamu because it's far, it's remote. They want to be in urban areas. So those are some of the disadvantages of devolving maybe the human resource. Okay. And if you can have a way of having, even now, because I know through Parliament we can be able to do it, you know, where we can have a health services commission. So where if a county, like Murang'a County, then the doctor decides they want to go for further studies, then the national government will replace the doctor. Some of these specialists, they are not enough. For example, oncologists, we have very few in Kenya, where they can be able to be in a schedule. So we know like one oncology can be given a region, like central region. So Monday you're in Kiambu, Tuesday you're in Murang'a, Wednesday you're in Nyeri, Thursday you're in Kirinyaga, then Friday you finish in Embu. At least those are some of the shared resources that can happen. And I think we need really to revisit on the human resource and to make sure that the health workers are taken care of. That issue of delayed salaries sometimes has really not gone very well. And then we find that the services are also not good. And I think number two also is on the, you can go and find a doctor, but then there are no medicines. So part of the UHC is also to make sure that when people visit the medical facilities, or especially the public facilities, you'll be treated and given the medicines. Today I was in Kigumu, and when I was leaving, a lady just gave me a note and said, I have been treated, but I've been told to go to buy, you know, the medicines, a chemist, and I have nothing. So such issues are the ones that we need to really harmonize. Apart from now, looking at the cost, but also we should make sure that when a person comes in, they are served to the end that they go home even with the medications that are required.
Speaking of harmonizing costs, teachers are asking that how come they're not getting the service they require despite paying top range. In fact, they're putting it at 1,700.
Currently, teachers do not have an enhanced scheme with the NHIF. So, but they're on the national scheme, so the benefits that are there for the national scheme are available also to them, and I think it's also used with the scheme that they have currently. The other thing that I also wanted to mention in terms of standardization, because that is the way that we are going even in our reforms right now, what we're calling the prospective reimbursement, whereby we have packages that the hospitals agree to. So the issue of costs running amok or having unpredictable costs actually disappear. And then now hospitals concentrate on providing high quality services within the funding that is available. And that is now the progressive way that we're looking forward, that we'll be able to contain costs. But also, as has been said earlier, it's also good to break down what drives the costs of healthcare. And one of them, 40 to 70% of the costs is actually pharmaceuticals. So we need that to also be addressed so that we can be able to contain the costs. And also, as we look at other inputs, especially the advanced forms of treatment and how they can be subsidized, or do bulk procurement through our agencies like KEMSA to help the counties, but also to help the counties in terms of managing their human resources, etc. And this is contained also in the Act, that the reimbursements that come from NHIF, if they can be retained within those facilities, so that they are used for the development and running of those facilities, in the long run would be able to achieve a sustainable model that keeps feeding itself.
A lady from Githurai, she calls herself Githurai's finest, says, my mom needs urgent MRI and endometrial biopsy at KU referral for diagnosis of possible endometrial cancer. NHIF has refused to pre-authorize.
I would like to have the details of that, and those are some of the huge benefits that we are actually having at the moment, because like oncology cover and the diagnostics is among our top 5 reimbursed packages. So I think it would be good even for Githurai's finest to call our call center, or even just to write, because even on our website we have like almost 20 numbers and different ways that they'll be able to contact our care center.
She's actually sent a screenshot for saying that NHIF not approved. The number is 600-5296, self Mary Wanjiru.
I think the easiest way is just get the number of Githurai finest. The CEO is here, and he can be able to sort it out after this show.
Absolutely.
Githurai's finest, send your number through right now, then we sort this out as we go. All right, Mwesh, so isn't there no punitive action that can be taken? Because all these things that I'm talking to you about, they do happen. Bodies are detained. Patients are detained. You walk into a hospital, you have to pay up front. an ordinary Kenyan can't fight an entire institution. You go there, all you have to do now is call your relatives. Isn't there a way that this can be done such that there's such punitive action that hospitals don't take advantage of the poor Kenyans?
I think it's for the board to up their game. That's what I'll say. And part of the reforms that we have had and among the challenges that we have faced, and this is very sensitive to say it because majority of these boards are also managed by the same people. So find that if it's a doctor who is in charge of a board, they don't want to, there's conflict of interest. They don't want now to take action against their colleague. That has been really a big challenge. So what I would just say is the board to let people report these cases, and I would like the board to take up this matter. Okay. Because as the laws, if the laws are there, the next thing is about implementation, and that's what needs to be done.
Okay.
Yeah.
Let's see how this evolved. We were talking about that. There's so many questions that keep coming that I can't even sift through all of them. Alex Musembi is saying that, mark this tweet, based on today's discussion, you will soon see a crowd of people going to insist that their bodies have to be released, their loved ones have to be released by force, because now they're thinking that's the way to go. As Frank says, as your voluntary contributors pay a standard amount of 500, while employed persons in private sector pay up to a maximum of 1,700, but NHIF have put them in the same category, yet public servants are given more favorable cover.
Yes, and in terms of, this is the principles of equity. Yeah. In fact, for the salaried folk, they start paying from 150 shillings to the 1,700. And actually about 13% of the people in that category actually pay less than the 500. Now, in terms of standardization for the informal sector, that's the figure of 500 per month, which caters for the principal member, their spouse, yeah, and as many children as there are who are below 18. Okay. So the cover is actually quite wide and very equitable. All right. I know the question of civil servants has kept rising over and over again, but it's good to understand that NHIF, as part of government to government, we do have an enhanced scheme for the civil servants, just like many other employers do purchase like private insurance for their members. Now, in terms of a government to government arrangement, they do pay extra premiums, yeah, to get that slight extra cover, as part of what we call employee benefits. Okay. And that's where things like the group life and work injury benefits, which other employers are supposed to do pay. So okay, that government has taken its role in paying for its employees. Okay.
Ladies and gentlemen, we have run out of time here, but I'll give you a chance for closing remarks. Honorable Sabina, what should Kenyans look forward to going forward on this health issue? How will it be streamlined? Yes, as I urge my colleagues to come in numbers and support the NHIF amendments and other health laws amendments that we have in the course of the week and next week, I just want to urge the county governments to focus on preventive. And I think a lot of it, even what you're talking about now, you're talking about when somebody has gone to hospital and what they need to be done, which is now curative. We need to look at, you know, there was this saying, prevention is better than cure. Yeah. And I also want to urge all Kenyans, it's important that even if it's once in a year, go for a health checkup. A lot of things are happening and even messing us up. Something as simple as blood pressure, somebody doesn't know that they have it. You know, those things, diabetes, then you go to the issues of kidney, then there's dialysis, and all these things that are coming in. It's good to have a health checkup. Finally, it is important to have an NHIF card for yourself and even for your neighbor who cannot be able to afford. And instead of you going to a Harambe, through that 500 shillings that you'll contribute, that will cover you, your wife, and your many children, can also be able to cover other people who cannot be able to afford. So I want to urge all Kenyans that NHIF is a good cause. Yeah. Looking at it, you might see 500 shillings per month is a lot of money. But if you look at a cost of 1 kg of sugar that we take in and is also not healthy to our bodies, if you're able to sacrifice a little bit of these things and then we cover our own families, how many of us as Kenyans who maybe have own bodas or their own cars, you have an insurance for your boda, but you don't have your own insurance? So what do you love more? Is it that boda or your car or yourself and your family? So it's good we look at our priorities and prioritize healthcare and know that once you are able to contribute to NHIF, you not only take care of yourself, maybe in the family, but also maybe your neighbors and others who cannot be able to afford. And then together we can be able to save each other's life. Okay. Thank you. Dr. Kamunyo, closing remarks.
To all our members, because I see all Kenyans as members of NHIF, If you can pay, pay. Those who cannot pay will be identified and supported. The key to ensuring that we protect our family and loved ones is to outsource that risk of healthcare, because healthcare costs, and when it comes, it is unexpected. And when you buy and pay for NHIF, you transfer that risk and we step in there for you. To our legislators, that we pass the bill, because this bill will help our members, will help Kenyans, will help the fund to be sustainable, to be able to protect all of us, to get to universal health coverage, where every Kenyan has access to the quality healthcare they need without suffering financial hardship.
All right. Thank you so much for making time, Honorable Sabina Chege, Chair, Health Committee, and Dr. Peter Kamunyo, CEO, NHIF. And most important, thank you for all the views you sent through. Like we mentioned earlier on, this is a special program that in the special series that we're going to focus on healthcare until you feel the difference where you are. All right. Thank you so much for tuning in. My name is Trevor Mbija. Always a pleasure having you with us. Have a great night and a fantastic week ahead. Bye for now.